Now, manipulation and casting is one part. And if you remember, we said there are few absolute no-nos. You will not touch the calcaneum. You will not pronate the foot. You will not dorsiflex the foot. Why won't you dorsiflex the foot? Because the tendoachilles is the thickest and the toughest tendon, and the collagen there doesn't stretch. If you try to compromise by dorsiflexing the foot in the hope that you will avoid a tenotomy, you're mistaken. All that will happen is you will cause the tendon doesn't stretch, equinus remains, and you'll cause the midfoot to break. And you'll end up with a rocker bottom foot, which is a terrible deformity to have. It doesn't correct easily, and it's a disaster for that child. So we do not want that. Do not ever dorsiflex while you are manipulating. Supinate and abduct every time. The tenotomy is an essential part of almost over 90% of idiopathic clubfoot. 90%. So, at the back of your little thing, there are certain key performance indicators. And it says, item number 4, 90% of all children will receive tenotomy. 90%. There are key performance indicators, and the fourth one says 90%. And that's a fact, and you have to recognize that. So, percutaneous Achilles tenotomy is part, it's not considered a surgical procedure, it's part of conservative Ponseti's method of treatment. You will need it in majority of cases. The only children that do not need are the postural club feet, where correction happens in 3 to 4 casts and nothing more is required. And that's a rarity. That's not the norm. Most idiopathic club feet would need a tenotomy. Please get that right. And the Achilles tenotomy has certain characteristics that you have to remember. It's a complete transaction. It's a complete transaction. It's not a partial cutting. It is an important part to correct the equinus deformity. And it is an essential component of Ponseti's method of treatment. It is an essential. And if you fail to do that and you try to dorsiflex, you'll end up with a rocker bottom foot. We do not want rocker bottom feet in our clubfoot clinics. Please remember that. If you have it, then your manipulation is incorrect. You're doing a disservice to the whole program. So what are the indications to decide, does this child need a tenotomy or not? So the recommendation is a midfoot score of 0.5 or less and a hindfoot score of more than 0.5. Why didn't we say 0? We didn't say 0 because in all children, the crease may not disappear. But when we say midfoot score of 0.5 or less, it means the talar head has to be 0, the curved lateral border has to be 0. When I say hindfoot score of more than 0.5, why? Because the posterior crease may not disappear in all of them. It will be 0.5 at least. So therefore, it is more than, when we say more than 0.5, it is equinus, rigid equinus will be 0.5 or 1, or the empty heel will be 0.5 or more. So that's when we have a hindfoot score of more than 1, a midfoot score of less than 1, that's why we say that. So that's the important part. And it's a minor procedure. You may do it in the theatre, but done under local anesthesia. A lot of people, I've seen last week also, I was somewhere, they said, we do it under general anesthesia. No. No anesthesiologist. So no anesthesiologist will give anesthesia without an IV line. Many times we have seen IV line takes more than the surgery time, isn't it? Because little babies, these little infants Putting an IV line is a challenge. So you need to sometimes call the pediatrician also. Now of course Amazon is also marking an infrared thing which you can do to find the vein finder, it's called. Infrared vein finder is there. Despite that, I have found anesthesiologists and pediatricians struggling for the veins. It's a fact. So it's difficult. So if you need to poke so many times to get an IV line, one little injection for that tenotomy is far better. It works beautifully. I would have done over 8,000 tenotomies. 8,000. When I started 1997-98, I used to do them under general anesthesia. Till about early 2000, I did it under general anesthesia. Till the anesthesiologist, I did the tenotomy, did the casting. I'm waiting for the anesthesiologist to reverse the child. Sir, reverse nahi ho raha. Not getting reversed. My heart sank. Tenotomy took me 5 seconds to do. Under anesthesia, child couldn't be reversed. Child went on a ventilator. Came out of ventilator, touch wood, next day. 1 day of admission and heartbreaking time for the parents, for the surgeon, for everyone. I was miserable. After that, I've never done under general. I've always done them under local anesthesia. And over 8,000 cases, not one case of an incompetent endocrinologist, not one case, touch wood so far, of bleeding. I've done 2 hemophiliacs. Under cover of factor 8, not one case of bleeding. No complications. Touch wood, no infections. Earlier, being done in the theatre because access to these trays was easy. Now I've made it available in my outpatient. Now I do it in the outpatient place. I have my own spotlight where I do it under local anesthesia. All you need is a local anesthetic without adrenaline. Without adrenaline, because the neurovascular bundle is right nearby. Without adrenaline, local anesthesia, half ml is sufficient in the infant. In the older child or previously operated child, maybe a little larger volume. You need 2 people definitely. 2 people for manipulation and casting, 2 people definitely for the tenotomy. And an assistant to pass on the local anesthesia and syringes and things for you. That's important for you to recognize. So 2 people definitely required. And local anesthesia. After sterile, I just paint betadine and go on to the local anesthetic injections. And the assistant holds the foot in maximum extension of the knee and maximum dorsiflexion of the foot. It's important. Maximum dorsiflexion is important. Please remember that. If the maximum dorsiflexion is not there, when you cut the tendon with the knife, it wouldn't cut. If this is loose and you do this, it will just keep slipping. It won't cut. If it is stretched like that, if it is stretched, the moment a sharp knife puts there, it cuts, snaps like that. That's why you have the pop. It has to be stretched and the assistant has to hold it in dorsiflexion. If it is not maximum dorsiflexion, held nicely and stable position. Don't put it in complete prone position, no. Lateral position. If it's complete prone position, you're likely to damage something medially. We don't want that. It's lateral position. Okay? And a lot of people struggle to identify the tendon. Trick, just stretch the skin here. There will be a little depression that comes there. And the tendon is right under that. And it's more lateral than you think. The tendon is more lateral than you think. If you see on the screen, it seems beautifully, but here you don't see it that well. But if you turn around and just see here, you can make the depression. See that here. It's very nicely. On the TV screen, you can see it very nicely. Can you see the depression? And even in the chubbiest child, you will get the depression there. Just stretch the skin proximally, you will see the depression. Bang under that depression is your tendon. What is the surface landmark for the posterior tibial artery? Anyone? Posterior tibial artery, what is surface landmark? Midway between the tendoachilles and the middle malleolus. It's far away, don't worry. It doesn't get damaged, it's far away. And the exact site of the tendon, again, if you were to look, I have picked up, this is not there in the textbook. If you cut it low in a child, calcaneum is all cartilaginous. So you may cut into the cartilage, and cartilage is avascular, anervous, it may not heal. You may land up with a calcaneous deformity, we don't want that. And lower portion, see that the way the tendon is broad above, narrowest here, and then widens again. If you cut too low, you may do an incomplete tenotomy. If you cut too high, you again do an incomplete tenotomy. So where is the narrowest portion of the tendon? Narrowest portion of the tendon is right opposite the middle malleolus. That's the normal foot. That's the normal foot anatomy. But when the child is an equinus, the narrowest portion is a little above the middle malleolus. That's the site of tenotomy. And at that site, your tendon is far away from the neurovascular bundle which is there. And your narrowest portion here is so easy to cut. It's such a simple thing. You don't need any extra thing. There is a little bit of local anesthetic. You've done that and it cuts beautifully. So 1 centimeter above is what the book says, what Dr. Ponseti's book says, but the exact anatomy site is the narrowest portion, and the narrowest portion is a little above the middle malleolus tip. It cuts beautifully. And once you've done the cut, the assistant, sir, pop ho gaya. Snap, it's a vacuum phenomena. That pop is the vacuum phenomena. Suddenly the tendon slides up into the paratenon sheath and there is a pop. The assistant will tell you ho gaya. Suddenly there will be maximum dorsiflexion, and then you give a maximum dorsiflexion. Sorry, what happened? A maximum dorsiflexion cast you give in 70 degrees of abduction. So the 70-degree abduction will not happen until the tenotomy is done. At the end of tenotomy, maximum abduction will come 70 degrees if your tenotomy is a complete tenotomy. Sometimes you may leave some fibers, and if you've left some fibers, and chances are very high if you're done too low or too high. If you've done it at the right place, it will be a complete transaction. If you've done it right, there will be a gap between the tendons. If you've done it right, dorsiflexion will be good, maximal. When you've done it right, the abduction will be maximum of 70 degrees. Just remember that. If it's a redo tenotomy, can you do it immediately? You think it's not done right? You can take back the knife and then see are there any fibers left. You can take back the knife and feel for any fibers and cut them. Feel with you can feel with your finger. Your finger will tell you the feel that, oh, there are some fibers there. Go back in and cut it gently. You can go back it once or twice, but don't keep going back in and again. Don't fiddle around. Don't take the knife cutting edge medially, because then you're in trouble. Then you're likely to cause damage. So that's, see that? That's a video identifying the depression and injecting. Can you see I'm way above, more than 1 centimeter above. Half a centimeter local anesthetic into the skin, in front of the tendon, above the tendon, below the tendon. And press, wait for 2 minutes. Give sufficient time. And then go in and do the tenotomy. And in the tenotomy also, I'm not sure if you can see it. There's an older patient video that I have where, so I'm waiting. I'm not immediately jumping and doing it. Allow the infiltration of the local anesthetic to spread locally, and then only bring in. There the depression. There you can see the depression where the tendon is likely to be, and then use the blade. Which blade we use? Earlier I used to do a number 11 blade. Now always use the number 15 blade. And when you're putting the number 15 blade right opposite where the injection was done, cutting edge has to be cephalic. Cutting edge cephalic, push the blade in and turn just 5 seconds, it's cut. It's gone in one with a snap. I just turn the blade, the tendon was taut, it snaps right through. It just snaps right through. It's done. So that's the loop. So slower video done in an older patient. You watch carefully. Cutting edge facing cephalically. Push the blade in front of the tendon. There. Push it in. Then turn it around 90 degrees. So now the cutting edge is at the anterior portion of the tendon. There. It's anterior portion. Now I don't do a seesaw of a cut like a saw. No. I just press my finger against the cutting edge. The taut tendon snaps quickly. In a smaller child, it snapped immediately. In an older child, it takes a little while. Once it is done, suddenly there is about to happen, it's gone. See the dorsiflexion? Suddenly you have good dorsiflexion. It's so easy. Ponseti again knew war history. Ponseti knew that a complete transaction regenerates. Ponseti knew that. In World War, there were so many prisoners of war that they ran out of prison spaces. Prisons were ghettos with crowded, full of people, filthy places. No place for toilets also. So the Germans were looking for war prisoners of war spaces. And they found natural prisons. Sea on one side, steep mountains on the other side. But were they sure that they will not escape? No. So what did they do? They cut the 𝐸𝐸𝐿𝐴 of all the prisoners. So that they can't climb these steep mountains. Because you can't do vertical climbing also. So to prevent them from climbing, they cut the 𝐸𝐸𝐿𝐴. What happened? 6 months down the line, many of them still climbed and escaped because 𝐸𝐸𝐿𝐴 regenerated naturally. Those of you still suspicious of a complete transaction, go back and read a 𝐸𝐵JS paper looking at 1300 cases of 𝐸𝐸𝐿𝐴's rupture treated conservatively. Conservatively treated. How do they treat it? 3 weeks of cast in equinus followed by an AFO for 3 months and it heals naturally. Results are far better than operative treatment. Fewer complications, fewer non-healing ulcer. Biggest problem with operative treatment of a 𝐸𝐸𝐿𝐴's rupture is non-healing wounds. If you have done it, you would know it. You would have seen it. The wound doesn't heal. So, conservative treatment, far better results than operative treatment. Complete transaction. Complete transaction is the treatment of choice for Ponseti's sternotomy. Under local anesthesia, Ponseti always did it in his outpatient clinic. He never took any patient to the theatre. Never took anybody to the theatre. In fact, this is a true story. One of the senior pediatric orthopedic surgeons, Dr. 𝐬𝐨𝐜𝐢𝐚, he was the president of Pediatric Orthopedic Society like Dr. 𝐸𝐴𝐿𝐴𝐼𝐺. He was in Iowa or somewhere in an international meeting and it was a session on Clubfoot. And he was sitting at the back row, right at the back. And the discussion time was on. And at the time of discussion, a senior person sitting next to Dr. 𝐬𝐨𝐜𝐚 asked, "Do you treat clubfoot patients?" I said, "Yes, sir." "How many do you think you would have treated? What do you do?" "Oh, we do casting, but most of the time we need to do surgeries." "So how many do you think you would have operated?" He said, "Maybe thousands." So this gentleman said, "Oh my God, you would have ruined thousands of feet." Dr. 𝐬𝐨𝐼𝐚, who is a very respected, very good surgeon, very good with children, he was shocked. He looked him up and down. "Sir, may I know who you are?" "I'm Ignacio Ponseti." So it was Ignacio Ponseti sitting next to Dr. 𝐬𝐨𝐼𝐚. And he was convinced posteromedial soft tissue release is not the answer, but sternotomy surgery is not part of that extensive release, it's just a minor release. Ponseti was convinced surgery was not the answer. Ponseti was convinced a simple manipulation and casting followed by sternotomy is all that is needed for these children. So remember, Regeneration is complete in a child, in an infant in 3 weeks. Older patients, it may take 4 weeks. Anybody more than 2 or 3 years, you need 5 weeks. Anybody more than 5 years, we give 6 weeks. What is the upper age limit for tenotomy? This is a very old slide of mine, I think 2003 or something. I had one patient, the tenotomy didn't work. So don't open up, you can't open up at that stage. So people say, how does it regenerate? Read 𝐷𝐤𝐜𝐤 last. Tendo-Achilles does not have a true tendon sheath. It has a paratenon which helps regeneration, but it doesn't have a true tendon sheath in 𝐷𝐤𝐜 last. But some people say there is a good paratenon with regeneration. So it's a complete transaction. So how is it that it regenerates? The paratenon doesn't slide. The tendon slides within the sheath. The paratenon sheath is there. Within that, the regeneration happens in the hematoma. So that hematoma is important for regeneration. If you open up, the hematoma is gone, regeneration will not happen. That's why when you do a TL lengthening, the regeneration is not a full thickness regenerate, it's a partial thickness regenerate. When you do a tenotomy with the sheath intact, the regenerate is a full thickness regenerate. This is one patient, I knew it was a full thickness cut, but it didn't happen. So I didn't open up, waited for 5 weeks, went back in and opened up. There was this is only one in all these 8,000 plus tenotomies I have done, one patient with an accessory soleus. There's a literature report of an accessory soleus in a small number of cases. It's reported. Okay, and that time, what was the tendon like? See the regenerate? It's a full thickness regenerate. Quite unlike a TL lengthening where the regenerate is only half the width of the tendo-Achilles. Here it's a full width regenerate. So don't worry. You don't have to have any worry on regenerations. It works beautifully. What is the upper age limit? That's a patient of mine. I've taken a full picture just to show you the size of the patient. He was a 14-year-old boy in whom I am doing a total tenotomy. Can still be done. And can you see that? Depression is the site of the tendon. Can you see that? That's a depression. You do the tenotomy. Earlier I used to do number 11 blade. I no longer use number 11 blade because number 11 blade is sharp, it's broad, cutting edge, it can go and poke through the other side. And in these older patients, you may not have immediate dorsiflexion. Why won't you have immediate dorsiflexion? Because older patients have been walking around in equinus. If you remember your AO principle of fracture treatment of the interosseous syndesmotic injuries, what do? When you do put a syndesmotic screw, you put a syndesmotic screw with the foot in maximum dorsiflexion. Why? The anterior body of the talus is broader than the posterior body of the talus, which is in the ankle mortise. So you put it in maximum dorsiflexion because you don't want to pinch the body of the talus. Okay? Similarly, if the foot has been in equinus for too long, the anterior portion prevents it from going in all the way. It is broader and therefore it doesn't get correction immediately. You will get the feel of the depression of the tendon right there. That's a 23-year-old girl in whom I did tenotomy, complete transaction under local anesthesia. People say you can't walk on tiptoe. You can walk on tiptoe. Full regeneration. Same girl. I have done 23 years walking on tiptoe. I was at a 𝐬𝐸𝐜𝐤𝐢 meeting in Rome. After a Clubfoot session, few of the people were there talking. So I was with somebody else. 2 Americans were talking to each other. I learned they're Americans later on, but 2 of those apparently American accent people were talking. I have to go back, and I was overhearing them. I have to go back and do this 5-year-old immigrant who has come to me, untreated clubfoot, needs a TL lengthening. I'm planning. I've given a date for surgery as soon as I get back. I was overhearing him. He was saying TL lengthening. So I said, excuse me, sorry for eavesdropping, but can I suggest something? You can do a tenotomy in this child 5-year-old boy, you can do OT, not me. You don't need to do OTA lengthening. He looked me up and down. You're kidding. I said, no, I'm not kidding. You can do OT, not me. You have 2 minutes? He said, yes. I had my laptop, opened my laptop, showed him the video. He said, oh my God, that's great. I'll have to go back and redo the counseling for the parents. I can do it in autonomy. You can do it in autonomy. The oldest patient I've done is 36-year-old. It works beautifully. They don't start tiptoe walking in 2 months. It takes about 6 months, yes, for tiptoe walking, but they can do it. And the regeneration is complete. It is possible, it's doable, and it's needed in more than 90% of cases. Thank you very much.